Today we'll talk about calcium channel blocker toxicity and its treatment. Calcium channel blockers are used for the treatment of the blood pressure, irregular heartbeat, and also to relieve the chest pain, migraine headache. Calcium is needed for automatic beating of the heart, called automaticity, for the conduction of current along the nerves, for the squeezing or contraction of the muscles inside the blood vessel, and also to maintain certain amount of like tone inside the vasculature. And for all this, we need the calcium actually. When the muscle contract, how strong will be the contraction? It depends on how much calcium is available around. In presence of calcium, the actin and myosin they interact, overlap each other, resulting into contraction of the muscle. When calcium channel blockers actually patient consume those, these drugs can prevent the um, calcium from entering inside the cells, and this can lead into like relaxation of the walls of the arteries and also slowing down of the heart. Some of the commonly used calcium channel blockers are amlodipine, nifedipine, diltiazem, verapamil, nicardipine, nisoldipine, clavadipine, nimodipine, and isradipine. Now, chemically, they are classified into three different categories: phenylalkylamine, for example, verapamil; benzothiazepines, for example, diltiazem; or the dihydropyridines. A lot of calcium channel blockers fall under this category, like amlodipine, nifedipine, nicardipine, nimodipine, nisoldipine, felodipine, isradipine, and clavadipine. Now, when it comes to calcium channel blocker toxicity or beta blocker toxicity, how prevalent or how common is this toxicity? When you look at out of all the various cardiovascular drugs used for the used in different treatment of the heart, actually different types of treatment of heart, the calcium channel blocker and the beta blocker toxicity alone causes about more than 65% in the patient, like more than 65% of the, death are just because of the um, CCB or the beta blocker toxicity. 18% of these CVS related deaths are mainly due to amlodipine, which is one of the most commonly prescribed calcium channel blocker. When it comes to clinical presentation of these patients, it varies from asymptomatic patient may not have any symptom to very severe bradycardia, severe hypertension, and also metabolic acidosis to kidney failure. One important difference between the calcium channel blocker and the beta blocker toxicity is that in the calcium channel blocker, the patient's mental status remain intact, whereas in the beta blocker toxicity, because the beta blockers are lipid soluble, so they can easily cross the blood brain barrier, so they can alter the mental status of this patient. Calcium channel blocker can reduce the cardiac contractility, automaticity, conduction velocity, and this causes relaxation of the smooth muscle, resulting into vasodilatation. And as a result, the blood pressure drops. The extended release formulation of these drugs, especially the nifedipine, forms a clump inside the GI tract. This clump is normally indigestible, and we call it bezos. So when these patients consume this, the whole idea is to get whatever is in left over in the body to wash it off, to get it out of the system, out of the gastric tract. Um, when it comes to other toxicity related to the CCB is mainly metabolic acidosis. Calcium is one of the intermediate body needs for the release of insulin. When calcium channel block the insulin, this creates a kind of condition like the diabetic patients have. Like when we everybody knows, because diabetic patients don't have enough insulin or insensitivity. So in this case, it creating a similar situation. So something called starvation acidosis. you know, Remember, in diabetic patient, the patient may look normal, but at the cellular level, the cells are still starving. The cells are still hungry. There might be a lot of sugar circulating in the body, but the cellular level, the body is still starving. So generally, body burns the carbohydrate like glucose as a source of energy. So as a result, we get carbon dioxide, water, and energy. Carbohydrates are like a clean fuel. All you get is a very like highly efficient, clean energy actually. Whereas, well, when the because of lack of insulin, body needs some kind of source of energy. If somehow not able to burn carbohydrate, then it switches over to burning the fat or the protein, mainly the fat actually. But when the body starts burning fat, you get carbon dioxide, water, energy, and unwanted product like ketones. So the buildup of those ketones can lead to acidosis, the pH drops, and that can lead to a lot of metabolic complication. For critically ill patient, the first thing you need to do is to secure the airway, breathing, and circulation. We call ABC. And if you need to intubate the patient, you might have to do that as well, especially if the patient is hemodynamically deteriorating at a very fast rate. Some clinician, they advise to give atropine to offset the vaguely mediated hypotension, bradycardia when during the laryngoscopy. So, since calcium channel blocker can cause hypotension, which is refractory to normally to the standard treatment, the IV crystalloid, IV fluids are generally given as initial resuscitation. But in order to maintain adequate circulation, these patients may require approach from multiple angles, simultaneously, like using IV fluid, IV calcium, using vasopressor, epinephrine, norepinephrine, glucagon, high dose insulin, and glucose. The conventional measures like urinary alkalinization or hemodialysis are ineffective in calcium channel blocker toxicity. This is due to the large volume of distribution, because the large volume of distribution means there's not enough circulating in the inside the in systemic circulation. So if it were more available in systemic circulation, we can do dialysis and get it out of the system. But because the large volume of distribution, so most of them distributed throughout the rest of the body, like at the cellular level. So well, dialysis may not be a good choice, but when patient have the acidosis, the idea is to maintain the pH like in around normal, right, 7.4. So sometimes they use sodium bicarbonate like to keep the pH around 7.4. But the whole idea, the best treatment for this patient is to wash the GI tract. Actually, they call whole bowel irrigation. That's the main treatment, especially for the mm, extended release formulation. You might need to consult the poison control and cardiology, like in some situation, like so the treatment recommendation for these treatment recommendation coming from the like Journal of Critical Care Medicine 2017. The guidelines specifically say that the first thing you need to look for or ask is the patient symptomatic or no. If the patient is asymptomatic, no signs or symptom like of a hypotension or bradycardia, like then monitor those patients at least for a day for 24 hours. If the patient has ingested toxic amount of the drug, toxic amount here I mean a single therapeutic dose. If the patient are symptomatic of toxic amount of the drug, the guidelines do not prioritize one treatment over the other. There are a couple of options they have offered. Sometimes many options are used simultaneously depending upon how severe the toxicity is. Sometimes they use a vasopressor or positive inotropic agent like dobutamine and or epinephrine to increase the contractility and the strength of the heart, especially in the cardiogenic shock. We can also use atropine 0.5 milligram every 3 to 5 minutes for patients who are experiencing the bradycardia. If the myocardial dysfunction is present in this patient, the guidelines recommend incremental dose of high dose insulin and glucose or the IV lipid emulsion. When it comes to calcium chloride generally available in two different formulations, calcium chloride and calcium gluconate. calcium chloride contains is 3 times more potent than the calcium gluconate, so make sure the patient has the central line, like when you're considering giving the calcium chloride, because it's highly irritating and lead to phlebitis. As far as the dose is concerned, IV calcium chloride is 1 to 2 gram, which is like 10 ml to 20 ml of the 10% calcium chloride injection. You can give via central line, very slow over 5 minutes. You can repeat it every 20 minutes, or you can, I mean, if you're giving as a bolus, over 5 minutes, or you can continue using as a infusion, continuous infusion at 20 to 40 milligram per kg per hour. You titrate it based upon the hemodynamic response of the patient. The faster administration of the calcium can lead to hypotension, atrioventricular dissociation and ventricular fibrillation. So IV calcium gluconate, the dose is 3 to 6 gram per dose. Give it over 10 to 20 minutes, or as a continuous infusion at 60 to 120 milligram per kg per hour. Again, you titrate it based upon the hemodynamic response. The effect of calcium is very transient. I just mentioned here some reports where they have given like up to 18 gram of calcium gluconate, over a 3 hour time frame. When you're giving calcium, make sure you monitor the calcium level, serum or ionized every couple of hours, every 4 to 6 hours. If the patient coming with a massive dose, then you monitor the calcium level more frequently. The idea is to maintain the serum ionized calcium. Some of them recommend to maintain the goal like twice the normal. The other option they recommended by this guideline is the high dose insulin and glucose. This thing. So IV insulin at 1 unit per kg as a bolus, followed by continuous infusion of zero point 0.5 to 1 unit per kg per hour. That's a massive dose of insulin. As a matter of fact, you titrate up the insulin until the hypotension is corrected, or a maximum dose of 2 units per kg is reached. And um, generally the insulin takes a little time to kick in, so generally about half an hour to 30 minutes. Some reports they have used very very high dose bolus of insulin, like 10 units per kg, 10 units per kg, and continuous infusion of 10 units per kg per hour, without any without major adverse effect. uh, what make sure once the hemodynamic parameters are stabilized, gradually decrease the insulin infusing. When you giving this thing the insulin, make sure you monitor the blood glucose potassium level every half an hour to 1 hour until they are stable, and then you can start monitoring them less often. If the patient develops hypokalemia, make sure you treat it very aggressively. And since insulin going to drop the blood sugar, try to maintain the blood sugar between 110 to 150 milligram per deciliter by adding D5W or D10, usually starting at the like a zero point 0.5 to 1 gram dextrose per kg per hour. One, I mean, when it comes to the dextrose infusion rate. No, since these patients are getting, end up getting a lot of fluid. I mean, because while we're treating the acidosis, um, generally as a commonly we use like 100 ml per kg per day, like the fluid in adults and pediatrics. For example, if the patient weighs 70 kg multiply 100 ml per kg per day, so patient is supposed to get about 7 liter of the fluid in a day. But in these patients, when they're suffering from acidosis, they end up receiving anywhere from 5 to 10 ml per kg per hour. So if you consider the same patient, 70 kg patient, so based on 10 ml per kg per hour, this patient will end up getting 17 liters of the fluid, and that's a lot of free water actually. So in order to minimize the volume, you may consider using the alternate solution like adding D10 half NS to minimize the free water. Some references actually recommend using infusion or pushes of the dextro 25% in water via central line. And the other third option they're giving is the intravenous lipid emulsion is also recommended by these guidelines in calcium channel blocker, overdose patient, and some other lipophilic agent. There are many case reports in literature using the fat emulsion for toxicity due to lipophilic agent. The mechanism they think is that it causes the partitioning of the lipophilic compound in the blood, so therefore it prevent the chemical from reaching the site of action. Most of the studies have used 20% lipid emulsion via IV as an IV bolus, 1.5 ml per kg. You give it over 1 minute. If there's no response, you may repeat the same dose every 3 to 5 minutes for total of three doses actually. Following the initial effective bolus dose, it's recommended to start the fat emulsion infusion at 0.25 ml per kg per minute until patient gets hemodynamically stable. Typically, generally, the duration is usually half an hour to 1 hour. The maximum FDA recommended dose for fat emulsion is 12.5 ml per kg. Now, since we have gone through the guideline, this thing by the Journal of Critical Care Medicine, let's consider a calcium channel blocker patient, a 53-year-old female with a past medical history of hypertension was brought to the hospital by EMS. This patient can actually ingested 30 capsule of diltiazem 240 milligram, basically coming like 7,200 milligram. When patient was brought, she was, although alert oriental, blood glucose 172 milligram per deciliter, vital temperature 98.6, heart rate 56, blood pressure 65/50, respiratory rate 14, oxygen saturation room air 96%, electrolyte sodium 140, potassium 4.1, chloride 101, bicarbonate 25, BUN 15, and serum creatinine uh, 1.1. So, based upon the guideline, what do you think would be the best option for this patient? Should we give the activated charcoal, or do the whole bowel irrigation, or give activated charcoal and do the whole bowel irrigation, or no gastric decontamination? Now, a couple of things you need to look at it when you're choosing the treatment. The timing of ingestion of the drug is very important, and looking at the symptoms of the patient, very important. Now, since this patient was brought to the emergency department within like 4 to 6 hour time frame of after ingestion of the extended release formulation of diltiazem, her blood pressure was low, her heart rate was low. Therefore, I think this patient will get maximum benefit from using both the activated charcoal and, as well as whole bowel irrigation. Thank you.